Thank you, Mr. Chairman. First of all, let me thank the organizers for their kind invitation, especially Kostas Sparias. Transcatheter aortic valve implantation is an established procedure over the last 15 years, well documented, but still complications happen. One of the most life-threatening lethal complications is coronary obstruction, which according to the TVT registry, it happens at 0.4%. This registry that was conducted from 2012 up to 2014, including 26,000 patients. Same results from the Spanish National Registry, which included 13,000 patients from 46 centers in 12 years from 2009 up to 2021. Low incidence of coronary obstruction, 0.8%, no temporal trends, which means that despite the fact that we have been improved throughout these years, with new technologies, more experience, this complication still happens at the same percentage. More interestingly, the coronary obstruction does happen in the cath lab. 80% of the cases happen during the procedure. In hospital, just after the procedure, in 10%, and 6% of the cases are presented as a late complication. Unfortunately, the mortality is high. The in-hospital mortality is 37%, while the one-year mortality is up to 50%. The balloon expandable valve presented here with the red dots is related with the acute coronary obstruction, while the self-expanding valves are more responsible for the delayed coronary obstruction, mainly because of the mechanism of the nitinol frame of the self-expanding valve, which still expands within hours or even days after the valve implantation. The incidence of delayed coronary obstruction, according to the valve type, shows that the self-expandable valve can cause more frequently coronary obstruction, but more significantly is that the valve-in-valve per se is an independent predictor of coronary obstruction. That's why the mortality is 50%, is extremely high in these cases. The most common clinical presentation of delayed coronary obstruction is the cardiac arrest. If this happens within the 7 days after the index procedure, later on the patients complain of unstable or stable angina. The left main stem is the artery that is more frequently occluded, almost 90% of the cases, while both arteries, left and right coronary artery, are occluded in 20% of the cases. Here are the most important anatomical and other factors that are strongly associated with the coronary obstruction. The anatomical factors are the coronary ostia height less than 12 millimeters, the sinuses of valsalva diameter less than 30 millimeters, the cusp height to be higher than the coronary height, low STJ height and narrow STJ diameter, the valve to coronary distance less than 4 millimeters, which means that the distance from the coronary ostia up to the final position of the displaced, degenerated valve leaflets to be less than 4 millimeters, a high predictor of coronary obstruction. The presence of extreme calcification in the culprit leaflet more than 600, and of course valve-in-valve, as was already mentioned, is an independent predictor also for coronary obstruction, mainly in the stentless bioprosthetic surgical valves or the stented BSV with externally mounted leaflets like trifecta and Sorin MitraFlow. Female sex is also related with high risk of coronary obstruction, mainly because of the smaller anatomy. And here is a proposed algorithm in order to predict the risk of coronary obstruction, cusp height more than the coronary height or coronary height less than 12 millimeters, valve to coronary distance less than 4 millimeters, and finally the culprit leaflet calcium volume more than 600 are all independent predictors of high risk production and in this obstruction, and in these cases we may consider coronary protection. Valve-in-valve cases, according to the VIVID registry, are also high-risk procedures. The risk of coronary obstruction if a stented valve is already in place with externally mounted leaflets is 6.4%, while the stentless valves cause coronary obstruction in 3.7%. And here are the characteristics of that we have to take into consideration when we do valve-in-valve TAVIs, the type of failed valve, the failure mechanisms, the dimensions of the transcatheter heart valve that is going to be used, and if it will be intraannular or supraannular, the coronary reaccess, the peripheral access, and some procedural aspects of coronary protection. This is a very well-designed trial which examined the independent predictors for coronary obstruction. According to this multivariable analysis, the only predictor of coronary obstruction was the stented with external mounted leaflet or stentless bioprosthesis with an odds ratio of 7.67, while in the model of the CT cohort, the VTC was the only independent predictor with a odds ratio of 0.22 by 1 millimeter increase. And this is why we talk about the VTC cutoff of 4 millimeters, because according to this trial by Ribeiro, the sensitivity of VTC cutoff is 85% and the specificity is 89%. And this is another proposed algorithm for valve-in-valve TAVIs, how to deal with these cases in order to prevent coronary obstruction and how to do further coronary protection. TAVI is a procedure that will be used in the near future in higher percentages, mainly because they have the TAVIs we shifted to younger ages, and the risk of coronary obstruction in these cases is 0.7%. This low percentage is mainly because of bias, selection bias. As before TAVI, we choose our patients very carefully. And if we are planning to do a TAVI, we have to predict the risk of coronary obstruction by taking into account the risk plane of the previously implanted balloon expandable valve. If the engagement of the catheter is above the coronary, the risk plane, then this TAVI is feasible. If it's beyond the risk plane and the distance from the transcatheter heart valve to the aorta is more than 2 millimeters, then it's still theoretically feasible. If the engagement of the catheter is beyond the risk plane and the distance from the valve to the aorta is less than 2 millimeters, this is unfeasible and there is a high risk for coronary obstruction. Here are the strategies to prevent coronary obstruction during TAVI. Exhaustive imaging evaluation and adequate planning. Sometimes have to reassess the risk and maybe we may favor surgical aortic replacement if it's doable and the patients are not inoperable. Coronary wire protection, chimney technique, basilica technique, and the unicorn procedure. And by protecting the coronaries with a wire, we know from the Chimney International Registry that we decrease the rates of mortality. Here is a case of coronary wire protection. I think we are experienced with that. 74-year-old male patient with congestive heart failure, structural degeneration and dysfunction of the aortic valve bioprosthesis, predominantly incompetence, previous medical history of surgical AVR with a 25 millimeter Sorin mitral flow, externally mounted valve, and ascending aortic aneurysm with surgical repair. A pacemaker was implanted at the same session in 2014. Paroxysmal atrial fibrillation and chronic atrial failure. The distance to the coronaries, the VTC was large enough, 6.8 millimeters in the left coronary and 6.5 millimeters in the right coronary artery. So in this case, we knew from the beginning that the risk of coronary obstruction was low. Nevertheless, we used a balloon, and over the balloon, we introduced an extension guideline catheter in order to have a stabilization of the guiding catheter. We deployed a 23 millimeter Sapien 3 ultra valve, a relatively high implantation, no paravalvular leak as used to be in valve procedures, no intervention, no need for any intervention to the coronaries. Chimney stent technique is also a very good alternative in particular cases with very high risk for coronary obstruction. This is a case of chimney stent technique that was done in our institution. 79-year-old female patient, congestive heart failure, severe degeneration of the bioprosthetic aortic valve. previous medical history of redo aortic valve replacement, so she had already 2 surgical operations. The last one was in 2012 with a 21 millimeter Sorin mitral flow. The pacemaker was implanted in 2021. This is, and here you can appreciate the very low takeoff of the left coronary artery compared to the mitral flow valve, and the narrowing of the aortic root at that level. The coronaries were protected with wires. A stent was placed in the mid part of the LAD. Self-expanding Evolut Pro Plus 23 millimeter valve was deployed, which was post-dilated, relatively low implantation, no risk for pacemaker here because there was already pacemaker. Excuse me. So you can appreciate in the left side, in the left-hand side video, that there is the left main was almost occluded at the ostium of the left main. Therefore, we retrieved the stent, we deployed it, we flared it, and the final result was good. No significant leak, paravalvular leak, so we finished with that result, and we are very satisfied from the final result. Basilica technique addresses directly the problem of the coronary obstruction by lacerating the coronary cusp that is just in front of the coronary ostium in order to prevent coronary obstruction. It creates a coronary triangle flow through the coronaries are supplied. We have also some splitting devices. This is the shortcut from P-Cardia from Israel. Professor Dvirch published a small trial with 8 cases where the bioprosthetic degenerated leaflet was splitted by this dedicated device without complications. A very promising technique, and we'll see the results in larger scale trials if this will be the way to go for coronary protection. Finally, the unicorn procedure for TAVI in TAVI. This is done with using a coronary guide wire through the telescopic system of an Ablat's left guiding catheter and the microcatheter. We cause with the radiofrequency impulse a laceration to the coronary cusp, the bioprosthetic, the transcatheter bioprosthetic leaflet cusp. Then we dilate with the balloons, and then we deploy the valve. It's another way to go for coronary obstruction in TAVI. In conclusion, Mr. Chairman, ladies and gentlemen, to optimize outcomes in TAVI procedures, it is essential to identify patients at risk for coronary obstruction. These patients can be best identified by structured evaluation that includes specific CT measurements, coupled with appropriate preventive procedures. This comprehensive patient assessment can mitigate the risk of coronary obstruction. Further research is needed to validate the different strategies and emerging dedicated devices that aim to prevent that complication. And finally, as TAVI procedures continue to expand, identifying and managing the risk of coronary obstruction will remain an essential consideration for optimizing outcomes and improving patient safety. Thank you for your attention.
Mr. Georgiou, thank you very much. Your cases are very impressive. Okay, I would like to make one question, please. Sometimes at Georgiou Hospital we make many cases of left main, but we don't make valve operation. But sometimes we put a stent in the left main, and we don't know if we are protruding outside or we are in the left main. Do you prefer a special valve for this type of operation? I mean, if the patient have a stent in the left main, there is a special valve that you will prefer to put in this type of pathology?
It's a very good question. I think the most important in this case is to measure exactly the distance of the anticipated final position of the valve to the stent, the metallic frame of the stent in the left main, because it is the most important. And also it's very important when we do PCIs in the left main stent to flare the stent in order to open it better and to avoid the possibility to compress the stent struts towards the left main. I think there is no any answer to your question, exact answer. If one valve is better than the other in these cases, I think the proper and the very careful estimation of the distance of this valve that will be implanted to the left main is more important than the choice of between the valve expandable or the self-expanding valves.
Thank you very much. Do you have any questions from the audience?
It's okay. I think this is a fundamental topic. It will soon become fundamental topic in clinical practice, the obstruction, the coronary obstruction, and all the measures. What are these cases where the preventive measures are not so sufficient at all? And you better send these patients to the surgeon. Okay, you need a sophisticated imaging, you need some other things, but what are these cases that you better send it to the surgeon, even, I mean, you better avoid the cases to be for TAVI.
I think there are cases where there is diffuse severe coronary artery disease, left main stem disease, and the patient is still operable. Yeah. In these cases, maybe it's better to proceed with surgery in order to have a bypass surgery and surgical aortic valve replacement in the same session. In my country, unfortunately, from years 2013 up to 2020, the majority of the valves were deployed, implanted surgically, were Sorin mitral flow. So you have all of these cases coming back over the last 2 years with degeneration of the valves. And in these cases, when there is a very high risk of coronary obstruction and the patient is still young, for example, 70, and has no any comorbidities, and we know from the beginning that we're going to need a stent in the left main, having in mind that there is a risk of stent thrombosis or extrinsic compression of the stent, or we have some issues with dual antiplatelet therapy. In these cases, maybe we have to reconsider surgical treatment. And we have to keep in mind that the surgeons improved significantly their techniques, and the risk of redo surgery is not so high if the patient is still young and has no any comorbidities.
Dr. Iakovou?
Yes. Dr. Iakovou, yes. Yes, thank you. So if I may add to that, and also the question of Dr. Patsurakos as well, we have to pay special attention in order not to deform the stent which is hanging in the aorta, the left main stent. I think this is very important, and it's very important how to do the chimney technique. I think it's
maybe to finish with a kissing balloon, Yannis. Sometimes.
Yes, that's what I was adding. Yes, in some situations we need to do a kissing balloon with the inflation with the balloon, the post-dilatation balloon of the valve. So you have to be really careful in order not to deform the stent. And another good thing that we need to keep in mind is there is also delayed coronary obstruction. So some of the sudden deaths that occur in this category of patients actually occur because of the delayed coronary obstruction. So that's why we are generous in chimney technique. So when you have a very narrow VTC, I think it's prudent to do regardless a chimney technique. We have a small series with CTs that follow up to 1 year. So if you do a proper chimney technique, all of these stents will be patent at follow-up. And the last thing is that I would like to point out is, of course, we talk about basilica. It's very rare. It's the learning curve is very steep. I don't think someone has done any basilica procedure in Greece. And also the shortcut device, we know that it's not available in Europe. So we are limited in terms of how to better, prepare these patients. So in these situations, I think patients need to be referred back to surgeons, and that's why it's very important for them to participate in the heart team and the decision as well. of how to better treat these patients.
You know you have coronary disease and you think you're going to be coming back, and you chimney them, good luck.
Yeah,
especially
exactly.
with a self-expanding valve.
Yeah, with any valve. Once you have a chimney, you can't get back into that thing unless you're extremely lucky. So that's your last shot at the coronary. So just remember that you've now.
I think this is very, very important as we treat younger patients. So if you do a chimney procedure in an 80-year-old patient, most probably you'll be fine if you have taken care of the coronaries before. But if it's another question, another question if you have if you are dealing with a 65-year-old male, yeah.
Okay, if you have a question, just tell us your name, please.
Dr. Kilic from Turkey. Dr. Georgiou, very excellent presentation. Thank you. Nowadays, we are not seeing so much, but TAVI in TAVI will come. So these valves will degenerate, and in that positions, maybe we can see much more coronary obstruction, because one of the mechanisms of both delayed coronary obstruction and for future valve in TAVI is the Valsalva sinus sequestration. So this point is very important, and you underlined it also. For this point, for example, commissural alignment is also very important, because to do future basilica procedures, and also for the self-expandable valves, balloon valves in self-expandable, etc. What's your opinion about for future interventions? Should we learn basilica, or really I appreciated about the unicorn technique that you mentioned. Yeah. So it's also very important technique for future interventions.
I think the most important issue with the TAVI in TAVI is the sinotubular junction. So it acts as a bottleneck, anatomical bottleneck, and if the sinotubular junction is small, then you have a high risk of sinus sequestration and coronary obstruction, acute coronary obstruction. So here again, the anatomic measurements are very important from the CT, and sometimes you have to reconsider even which valve going to use, self-expanding in the balloon expandable valve or balloon expandable in the self-expanding valve. It's a very complicated issue. It's not so straightforward sometimes. There is no clear answer. Sometimes we don't have clear answer which valve must be used. We don't have a very large experience with this. We have done only few cases of TAVI in TAVI because 10 years ago or 14 years ago when we started, the patients were 80 or 85 years old. Now they are all died. So, but it's still something which is have to keep in mind that we're going to face it more frequently the next few years.
Okay, thank you very much. Mr. Tsigaderis, please, do you have a comment?
No, I just want to point out that the first implant is the most important one, and we should ask also our surgical colleagues to use valves that are friendly to us for barring valve.
Okay, thank you very much.